All right, so agents for treating RA, rheumatoid arthritis. So, big picture, what's the problem? Well, we have this TNF alpha inflammation and rheumatoid factor that's being made by B cells. How do we fix it? Symptom management. So we decrease non-specific inflammation acutely with NSAIDs and glucocorticoids. Don't want to be on those long term though. So that's acutely. So now then we want to modify the disease's progression. We can prevent synthesis of DNA needed for leukocytes that will eventually lead to this inflammation and rheumatic factor made by B cells with methotrexate, leflunomide, and azathioprine. We can decrease or modulate our lymphocyte action with hydroxychloroquine, or sulfasalazine. We can block TNF alpha, etanercept, infliximab, and adalimumab. We can block our B cells, rituximab. We can block T cell stimulation, abatacept, or we can block some of the interleukins with anakinra, canakinumab, and tocilizumab. So let's get into that. 29-year-old man with a 3-year history of hip and low back pain complains of morning stiffness of his back that is improved with exercise. His pain was initially controlled with NSAID use, but the patient no longer finds relief with this treatment. Otherwise healthy. His physical exam unremarkable except for decreased chest expiration. Very important sign. X-ray of the spine is shown. What is this? This is one of those. You got to know what this X-ray means when you see it. There's a, you guys should. There's a YouTube channel, like high yield USMLE stuff. One of the videos is like 30 or 40 pictures that are like extremely high yield for step. This is one of them. You got to know what this is. It's bamboo spine. Bamboo spine is what we look for in ankylosing spondylitis. So the physician suggests an adjunct medication to help control the patient's symptoms. However, potential serious side effects, adverse effects associated with the treatment. Which tests should be administered first? So this is like a classic. You got to know what medications we use to treat ankylosing spondylitis and what do we need to do before we put somebody on medication like this. I think we might have talked about this before. The answer is PPD. Got to test for TB because we're going to put this person on an anti-TNF alpha agent. Anti-TNF alpha agents inhibit TNF alpha, obviously, and the TNF alpha is the primary, I want to call it like an interferon or a marker. It's the primary substance that's causing the walling off via the macrophages of the acid-fast bacilli in the lung. So if you inhibit TNF alpha, you lose that ability to wall off the acid-fast bacilli, and now you got TB. Now you got a problem. So very important, ankylosing spondylitis, bamboo spine. You got to know that that's bamboo spine. But before we do, just talking about the sort of general treatment, because it's kind of confusing, and a lot of these agents, there really isn't direction. There's a lot of different things that you could technically do, but they don't really give you a lot of a good idea on what to do. So this is sort of our way of sort of simplifying the treatment steps. So the goal of rheumatoid arthritis treatment is to have low disease activity or ideally remission. So we can do this by treating with disease-modifying anti-rheumatic drugs, or DMARDs, and anti-inflammatories like NSAIDs or glucocorticoids. DMARDs are broken into two different categories, non-biologic and biologic. Non-biologic include methotrexate, leflunomide, sulfasalazine, and others. The biologics are all of the ones that impact TNF alpha and that are injectable. So the etanercept, infliximab, adalimumab, those are our biologic agents. Obviously, biologics are a little more expensive and are sort of reserved for moderate to severe disease. Also, as I had said before, are anti-inflammatories, corticosteroids, and NSAIDs. DMARDs should be started on a patient within 3 months of diagnosis. we need to start a patient on a DMARD. Treatment decisions are primarily based on the disease activity, the duration, the prognosis, and the current regimen. So, for an acute flare is somebody who's just been diagnosed, we're going to immediately start them on an NSAID with a corticosteroid. We're going to try to acutely reduce inflammation. Now, chronic treatment is when we start, adding our DMARDs. Our first line is going to be a non-biologic DMARD, most likely methotrexate. And this is going to be determined by, how early in the disease course, and if we have low disease activity, we can use monotherapy. Now, as the disease progresses, or we have moderate activity without a poor prognosis, we can also use a non-biologic DMARD. Now, we can also add two of them together. So we could give a methotrexate with a hydroxychloroquine or a leflunomide. It's more effective, and we also will always sort of anchor with methotrexate because that is sort of our go-to drug with the most efficacy when it comes to non-biologic DMARDs. If we try a non-biologic DMARD and fail, or in addition, the patient has a poor prognosis, highly active disease, early joint damage, rheumatoid factor, or ACP protein, anti-citrullonated protein antibody, then we start to think about adding on a biologic, or after an inadequate response to do non-biologic DMARD regimens in a patient without a poor prognosis. So you don't necessarily need to know those specifics. Just know we start with a non-biologic. Methotrexate's our anchor. If it's a little bit more severe, we can use multiple. And after a point, if they fail those non-biologics, we can use biologics. Now, including just a little bit of information on NSAIDs, because NSAIDs are so important in the treatment of rheumatoid arthritis, we just have some FYI slides on aspirin, ibuprofen, indomethacin, naproxen, and celecoxib, and our glucocorticoid slide that seems to be appearing in every single presentation we do at this point. Now, non-biologics. I believe we've gone over methotrexate before, so just a brief little reminder. This is our dihydrofolate reductase inhibitor, DHFR. This is our drug of choice for treatment of rheumatoid arthritis. And as I was saying before, during acute treatment, we use NSAIDs and corticosteroids because this takes about 4 to 6 weeks to work. Big thing with methotrexate, what are the side effects? Bone marrow suppression. So we're inhibiting dihydrofolate reductase. Therefore, we're inhibiting the process of generating some of the nucleosides that are very important in, creating our immune system. Therefore, by inhibiting this, we're going to start also getting into that crossfire of rapidly dividing cells, such as the cells of our bone marrow, the cells of our GI tract, the liver. Sort of just keep that idea in mind. We're inhibiting rapidly growing cells with methotrexate and some of these other agents. Therefore, we get some of those, sort of the physiological, they make sense. It makes sense if we're inhibiting rapidly dividing cells that, these things would get hit. So bone marrow suppression, stomatitis, anorexia, nausea, and vomiting. This actually can be minimized by a subcutaneous or intramuscular administration. And stomatitis, that is not inflammation of the stomach, that's gastritis. Stomatitis is actually inflammation of the gingiva of the mouth. So right by the, the gingiva, right where your teeth are. So that's stomatitis. It can also cause liver toxicity, including fibrosis and necrosis. Very important. Methotrexate is liver toxic, so you want to avoid alcohol. It can also cause a hypersensitivity pneumonitis, and it also I'm sorry, it's been a long day. It's also teratogenic, causing narrow tube defects. So we want to, if we do have anybody who is on this, or we probably wouldn't want to put a pregnant woman on this, or a woman trying to become pregnant because of that possibility. The antidote for some of these side effects that are folic acid linked is leucovorin, which is our folinic acid. Very important to know that side effects for methotrexate, those are highly tested. Leflunomide. Leflunomide is their dihydroorotate dehydrogenase inhibitor, or carbonyl phosphate pathway into orotic acid, which is, for the most part, in easier terms, a pyrimidine synthesis inhibitor. This is used for monotherapy in RA for those who can't tolerate methotrexate, so it's sort of given instead of. The max response is seen in the response is seen as 1 month, and max response will be seen in 3 to 6 weeks. Again, similar to methotrexate, we're inhibiting pyrimidine synthesis. We're inhibiting rapidly dividing cells that need pyrimidine, nucleotide. Therefore, you can see some of those effects: myelosuppression, hepatotoxicity, and this one is specifically contraindicated in pregnancy. So leflunomide is sort of a cousin of thalidomide, and thalidomide being the famous nausea and vomiting drug that was used in pregnancy that led to the flipper defects in children. We have hydroxychloroquine. So this is actually our anti-malarial drug that was also found to have some effect on RA. It has one of those nice mechanism of action profiles that is very nonspecific and sort of shows we're not too sure how it works. It can trap free radicals, it stabilizes lysosomal membranes, and it suppresses a lymphocyte response. Very, a lot of different mechanisms that really don't mean anything. Response is seen in 3 to 6 months. This is used for much milder RA because it doesn't have as much of an effect. This tends to always be used in combination with methotrexate and or sulfasalazine. It's pretty well tolerated. It can cause some vision changes. I believe hydroxychloroquine can cause cataracts. Big testing, high yield point. And another very high yield point, it's safe during pregnancy. So if you have somebody with an RA, you can give them, and they're trying to become pregnant, this is an agent you can switch them to in hopes to sort of controlling the RA in addition to allowing them to become pregnant. Sulfasalazine, technically we don't know how it works. It has anti-inflammatory effects, and it is considered an immunomodulator. Again, another agent that's used for mild RA, always used in combination with methotrexate and or hydroxychloroquine. Response is seen in 2 to 3 months. Lots of GI side effects: anorexia, rash, sulfasalazine. This is a sulfa drug, so you can get a sulfa rash. And this one can also be used in pregnancy. A few more drugs that you have definitely seen before and we have talked about: azathioprine. This is our fun little purine analog that's metabolized into 6-mercaptopurine and inhibits DNA synthesis by inhibiting the xanthine oxidase. It inhibits the breakdown of purine analogs, so breaking down and becoming an antimetabolite. So this is used in refractory rheumatoid arthritis with systemic involvement. It's a little bit of a stronger drug. Side effects can be a little bit more toxic. It can be used in induction and remission of irritable bowel. It can be glucocorticoid sparing. And it has a slow onset, so it's co-administered with methotrexate because it takes a little bit longer to work. Side effects include myelosuppression and hepatotoxicity. Always remember that our drug interaction with allopurinol and azathioprine, because we're inhibiting xanthine oxidase, which metabolizes azathioprine, so we can have a buildup of azathioprine. Very, very, very important to remember that drug interaction. It's really high yield. And then we also have cyclosporin. We talked about this with our transplant lecture. This is a transplant drug, a calcineurin inhibitor. It blocks T cell proliferation by preventing IL-2 transcription. Can be used for RA in addition to prophylaxis of organ rejection and treat graft versus host. The side effects we had talked about previously: nephrotoxicity, hypertension, hyperlipidemia, neurotoxicity, gingival hyperplasia. I wouldn't worry too much if at all, about cyclosporin. Even though it can be used as a non-biologic DMARD, we're not going to use this drug. This is a transplant drug. It's on the list because technically, I guess it can be used, but I wouldn't worry at all about cyclosporin. It was already tested. Now we move into our biologic DMARDs, or biologic disease-modifying anti-rheumatic drugs. We've talked about our TNF-alpha inhibitors. We have a few here that can be used. We have Intercept. This is our fusion protein binding and blocking the TNF receptor and TNF-alpha receptor, and leading to its inhibition. Infliximab, this is our monoclonal antibody. Remember, Intercept is not a monoclonal antibody. This is our chimeric monoclonal antibody that is blocking our TNF-alpha receptor. And important to remember, because it is chimeric, there's more likelihood that there is an immunologic reaction of the human body against this antibody. Lastly, we have adalimumab. This is Humira. This is a fully humanized anti-TNF-alpha receptor monoclonal antibody, so there's less of a chance of the body having an immunologic reaction against this antibody. TNF-alpha, remember, we can have injection site reaction. This is the actual swelling and you know, the reaction that you get where you actually injected the drug into the body. Infection, we can have reactivation of TB. Extremely important to remember reactivation of TB with TNF-alpha inhibitors. We can also have Hep B and all of the other hosts of infections. We can have certain cancers, because if we're reducing our body's natural immunologic response, there's a possibility that we may not have our cancer surveillance system activated if there is some sort of problem. You can have an allergic reaction. You can have demyelinating disease. Natalizumab, we remember Tysabri, can reduce our immune system enough to cause reactivation of the JC virus and cause MS-like symptoms. And cause PML. And this is primarily used in MS. It can cause systemic lupus-like syndrome. We can also have heart failure exacerbation and pancytopenia. These drugs are contraindicated in a patient with a history of TB or a positive PPD, active chronic or recurrent infection, or patients with heart failure. A few more biologics, our CD20 antibody, rituximab. So this is a chimeric monoclonal antibody against the CD20 receptor on the B cells. This can be used in a whole host of different things, but it can also be used in combination with a non-methotrexate and another non-biologic DMARD, and it is very useful for rheumatoid arthritis. Some of the side effects there is, in addition to, the injection-like reaction that most of these drugs do have, this one has an infusion reaction that is actually fatal. So there can be a fatal reaction to rituximab, and so I believe they do give a test dose, or it's always given in-house before, it's always given in-house, and I believe you do have to wait like a half an hour to an hour before you leave after you receive the drug to make sure you don't have this reaction. It can cause a reactivation or infection, and it can cause a reactivation of Hep B. So now we get into some of the more, funky biologics, which what I would know is just the mechanism of action. So we have abatacept. So this is another fusion protein. You can tell because it's the CEPT. It's not a MAB. This one is homologous to the CD28 protein, and so it can block the T cell receptor for B7. So as you guys remember for immunology, there are all those like stimulating receptors on B cells and T cells that can, cause our immunologic reaction and activating T helper cells and yada, 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 yada. So what this is doing is it's interfering with T cell activation via the dendritic cells that are CD8 and CD4. So what you guys need to know is abatacept is a homolog of the CD28, and it's going to block the T cell receptor for B7. That's what I want you guys to know. And it interferes with T cell activation. So T cells will not get activated with this drug. It can be used monotherapy for RA. There are infusion reactions, hypertension, headache, and anaphylaxis, and an increased risk of infection, which is pretty much seen in all of these. But now what I want you to focus on is the actual specific mechanism. If you can hone in on that, you should be okay. Moving forward, more drugs of that nature. We have an interleukin-1 inhibitor, anakinra. This is an IL-1 receptor antagonist. So hot T-bone steak, that little mnemonic, this is, IL-1 is primarily that fever portion. And so this drug is just inhibiting the IL-1 receptor. It can be used in combination with methotrexate, and it's actually considered the least effective DMARD. Canakinumab, this is a monoclonal antibody against IL-1 beta. Specifically, it's used for systemic juvenile idiopathic arthritis. It causes infections, abdominal pain, and injection site reaction. I would just know that canakinumab can be used for, it is an IL-1 receptor antagonist. That's what I would remember. We also have some interleukin-6 inhibitors, tocilizumab. This is a monoclonal antibody against IL-6. It can be used in patients with an inadequate response to one or more DMARDs, and also for systemic juvenile idiopathic arthritis. Like all of the rest, lots of reactivation of infections, headaches, hypertension, and increase in LFTs. As I've been saying, I would just memorize that this drug is an IL-6 antibody antagonist and call it a day at this point.